Hi, I'm Mark again. Okay, patient tracking. One of the coolest things that we're, in my opinion, that we're doing right now is a patient tracking module in WATrac. When WATrac first came out, I was like, okay, whatever. It's going to be, we're going to be able to see people. We're going to see hospitals. That's going to be great. Never fully understanding the capabilities of it. Mike Lopez and I have been honored to be asked, voluntold. I guess there's a couple different ways to describe how I ended up there, but anyways, I've been asked to be part of this group that's going to deal with patient tracking. Patient tracking for any mass casualty, as we just alluded to here a little bit earlier about Seattle. And that was 50 patients roughly, or 61 patients. Well, 61 or 62, 59, whatever the numbers were. That's exactly what we're talking about. That's on a relatively small scale. When you start thinking about Cascadia fault line, which is off the coast, which is predicted to send, and by the way, yesterday was our 300th anniversary of its last fault movement, which I believe created a 9.9 earthquake, I think is the number, maybe a little off, and a tidal wave that wiped out, I forget how high it goes up the mountains, but anyways, it's a very significant event, and it's just off our coast, and it's 300 years, and it's predicted to go off very soon again. Whether it's this generation, tomorrow, 2 generations from now, it's going to happen. It's just a matter of time. And they know the result, or kind of roughly what it's going to look like when it happens. And if you think about how populated Seattle is now compared to 300 years ago, there's a couple more people. So that's going to create a patient surge that goes more than just to Spokane. That surge of patients, after everything that happens is done, that's going to create a flood of patients coming this direction in the thousands. Not going to be able to go to Portland because it's kind of on the same fault line. It's down there in that same region. So when they start talking about thousands of patients being moved, and those are just the patients that are already in hospitals that are going to need another hospital to go to, because not many buildings are going to survive what they're predicting is going to happen, because historically that's what's happened. That's the level of earthquake they've had. So this patient tracking module is going to be a tool that we need to have up and running for tracking patients, whether it's 5 patients, maybe 50 on a bus, whether it's 59 or 61, or it's numbers in the thousands. One of the biggest problems with 9/11 or any of the other ones is they don't know who went where. They have no idea who they are. Hospitals are getting patients. Families are looking for them for days. There's pictures out on boards so people can try to identify them. WATrac put in a patient tracking module that we're going to just kind of briefly discuss right now that is fantastic. You can put in information starting off with a Sharpie and writing number 4 on their forehead. And that's number 4. They're going to a hospital. And you put it in the system, number 4 is en route to Sacred Heart. And that automatically, once you hit enter, it populates in there. Sacred Heart can see it. They're coming. Scene can see it and say, okay, they're still en route. Anybody who has the WATrac access can look at it and see what the status is of those patients. And now, keep in mind, that's still just number 4. We don't have a name yet. So that patient arrives. As soon as they get there, they hit next, and it automatically arrives the patient. So now anybody on scene knows that's where they are. Somebody comes up and says, hey, my husband was here. He's not here. Well, we've sent one to Sacred Heart. We don't have a name yet. And you can start inputting data, and you can edit that data at any time when you know more information. If you can guess their age, you can put a guessed age. Male and female, a little easier in this day and age, sometimes challenging. So you can start putting in information as you go. Once they get to a hospital, you can put in more information. If you can identify them, then you can go back and edit it and put it in there. So the nice thing is the people on scene, whoever's putting this in, if you have that capability, can then see who is where. And the hospital can see who is coming. And family members then can go up to, hopefully, to an established command center and say, my husband, Mark Sheldon, was here, and oh, Mark Sheldon is now en route to Deaconess, or whatever the case may be. It's a very useful tool for making sure that we're tracking patients. A couple of the reasons why we want to do this patient tracking. Distribution, maintain situational awareness, assist with family reunification. That's a huge one. It's not only to know who went where, but one of the biggest problems we run into is loved ones. They're our loved ones, and we want to know where they're in, and you were the last one to see them, so where are they? That's the question I'm going to ask when I'm looking for my child. And legal follow-up and investigation, and I'll extend that into how do we get paid. That's not something in the forefront of our minds as healthcare providers. Our forefront is let's take care of the patient. The reality is we need to keep our doors open, and at the end of all this, AMR needs to be able to say, hey, we did 76 transports. We need to know who they were so that we can make sure we're kind of following up, not only for better practices, but also so that they can go back and talk to insurances and all that. So lots of reasons that we want to have patient tracking. Concept of operations development. We're in a group right now that that is pretty diverse. I brought my list of who I had up here. Well, I left it at my desk. Anyways, so we had representatives from VA Hospital, who traditionally is a federal partner, kind of a partner, usually didn't get involved with everything, but now they have a pretty aggressive approach. They're like, we want to be involved. Yes, we're a federal entity, but we also want to have our doors open. Something like this happens, we want the doors open. You know, we're going to help. We'll work out the rest later. So they have a great attitude about kind of modernizing, you know, throughput. You know, they know that we're going to rely on them in these mass casualty things, and just because they're a federal entity, they're not untouchable. So they're willing to help. We had Deer Park Ambulance had a representative there who also works for Fire District 1, so he can help get that information up there. That's in Stevens County, kind of northern Stevens County or central Stevens County. We had representatives from, who else do we have? Well, we had Travis there. So the coalition is, AMR. So we're starting to get a group together to say, how does patient tracking at the moment of injury look? Moment of injury happens in Spokane, everybody's connected. We can get online and look. Moment of injury happens in Colville, you may have connectivity. That's right on 395. It happens over in Fruitland, which is about 15 miles south and west of there. You're not getting on a computer to put anybody in there. You can have a command center, and you could have as many computers as you want. You're not going to have WATrac on any of them. So our job and our goal is going to be to tell how we can best start this process of patient tracking so we can make sure it's successful in the long run. So we'll talk about it a little bit more here in a minute. We want to determine the coordinating agencies, who's going to serve as the primary leads, agency access, roles and responsibilities of participating agencies. When do we activate? When do we deactivate patient tracking? And we're going to be defining the steps of how this kind of looks. A real quick little brief on what WATrac's patient tracking piece looks like. When you go into WATrac, those that have access to it, there's a section of it called patient tracking right here in the middle. I didn't see it for the first year I had WATrac. And then we ended up going over to the coast and learning a little bit about it. I went over to Travis and we had a great demonstration. King County and their partners are active with it. They use it to what extent they can use it. When I compare those counties with ours, up north, we have a little bit different dynamic of who's going to put this in, who's going to track it, when it's actually capable of being put in due to the connectivity of the areas. So it'll be interesting to see how we progress into what we're going to do and how that compares to what happens in Seattle and the other side of the mountains where they've been pretty successful with it. So when you bring up the patient tracking module, you can look at, right now we have inactive things going on. Unfortunately, we don't have any live incidents going on at the moment. But the way it'll look is it'll be different incidents. So what will happen is somebody will put in your incident, and then when you click on whichever incident you want, it'll come up with the title of the incident, a description of just a basic description of what happened. Number of patients, is it a drill, yes or no? And that's the other beauty of this. We can do drills in this. We can do paper patients, and sometimes that seems a little bit monotonous, but when you're talking about patient tracking and you're actually able to get in and sit at a table and move these around and everybody kind of have their blinders on, and then 30 minutes later say, okay, where is everybody? And bring it up there. If we do that enough times, we'll we'll start to get this right. The problem is we need to get the right people at the table and then get that information out to whether it's law enforcement or get it out to the rural communities or the rural hospitals. And so once we get a kind of a good program going and we have an idea of how it looks, that's going to be, in my opinion, kind of the easier part. Harder part is going to be getting it out to all the facilities, getting the education and training down, getting them to do enough drills so that we can make sure we're successful when something bigger happens. I would love to be, I hope someday to, I don't want an event, but if it happens, I want to be as successful as they were. So. You can put in the different services you have, AMR, Deer Park Ambulance, Colville Tribe, different MedStar, Life Flight. You can put all those in there, and you can tie those into people's transports, which is nice. You can take a look at the agencies. You can start putting in agencies in there. So if you look at this, you've got a drill or an event. You've got a start and stop time. You have who is involved with different services in it. You have the agencies they were sent to. So it's a very easy system to start pulling reports out of too in the end. And that's important when we have to go back and start looking at after action reports, hot washes, whatever you'd like to call it that you do. It's a very useful tool. We can break this down into many different categories. So as we go into that event, look at the patients, we can take a look at the patients real quick. And I'm not going to go too much into what the colors mean. Basically, they mean green, you're great. Yellow, you're not so great. Red, you need to get to a hospital immediately and be taken care of. That's an emergent patient. And you'll notice there's no blacks on there. And the reason is because the color black in a mass casualty is they didn't make it. So not to get too much into that, but one of the hardest things to do as a mass casualty person is to step over somebody who's breathing and step over them and move to the next patient. And that is a job that's not for the faint of heart, but that's what happens because there's a set of criteria that patients, if they don't meet that in a true mass casualty, then you move on. And it's a very hard concept for healthcare providers. Well, actually hard concept for anybody to really kind of get their heads around. In the mass casualty, you're trying to save who's savable. And there's a lot of effort sometimes put on patients that don't have a survivability index you can work with. So a topic for another day. You have patients, you can tell that this patient's right here, Anthony James, was yellow. He's somewhere in between 19 and 35 years old. He's arrived at the facility and this is the time. This information is readily available by anybody who can look at WATrac at this moment in time. So that's important data. That's important data to the people on scene. Now the on-scene commander knows that this person is here, and they can actually judge kind of how many patients are at that hospital. Then they can start kind of helping direct and talk to DMCC, who's also looking at this, and say, where should the next patient go? Should we consider going to a different hospital because Deaconess has received, 4 patients and they're all really sick? If you get 4 reds at Deaconess over here and Sacred Heart only has a couple yellows, well, you can articulate we should probably start funneling a couple patients there, and we can see who's en route. So you can continually update this with patient information. I used number 4 earlier. I put this one in the other day. As we go, I can turn that into a number. I can turn this into, this could have been John Doe. And I think to start with, I didn't even have a name. And I went back and updated that. So it's real-time editing. And so it's a great tool for somebody who is trying to identify patient placement, where they need to go, find people, and so on. The information that there is on a patient. You can start off with just a very simple number, triage number right here. That's where I put my number 4 in, and I think I had 4 and male and triage status and sent them off. And then I went back and started editing what was going on with this patient. What's nice is you can do that when you get to the hospitals and you have registrars who are taking patients in and identifying them better, where you have family members show up on scene and they're identifying them. Patient tracking in this scenario is kind of, it's really easy to see, it's easily identifiable, and it's easily updated. And that's easily updated seems to be to me is one of the most important parts of it, because you never know everything about somebody when you first see them. Patient number 4 from the scene, then
triage number 5 digits. Is there a history within this person's screen, you know, that patient 4 became triage number, whatever, and then name?
Well,
the team may not know necessarily that number 4 they wrote on somebody's forehead became triage number X.
yes, and so I believe, and maybe Travis can explain this a little bit better, there is a section there where you can go in and you can actually do a note field, because I believe there's a note field in there that we can go to. You could even leave that number there, because this number is, so if we had set them without a name and all of a sudden they became Mark Samuels, then you could just leave that there and they would simply know that. So this number, I mean, you could set up your incident to be all these incident numbers. This is what you're putting in there. This is what you're doing when you're first on, you know, when you're on scene, putting them out there. So if you want to start with 1 through 150, you could start with number 1 through 150. You would never have to take this information out of the system. You could leave it there, and you could be 1, 2, 3, 4, 5, 6, 7, 8. These are just numbers people put in when they were doing part of the test patients, and so. But there are note fields buried in there that you can actually get to when you look at the patient. So, do you have any more to add to that? Okay, so right now, Sacred Heart does not use this patient tracking system. We are, I kind of represent both hospitals for this particular piece. No, we're not using it, and to my knowledge, nobody in the area is really using it. We are now starting to try to come up with how this looks in our area. The problem we have is who is going to be the first person to put these into the computer? And the reason I say that's a problem is because on scene, in a lot of our areas, we don't have connectivity. So you're not going to have this done on scene. So what does it look like before they get here? We used to have trauma bands for trauma patients, and it had a banded number, and so they came in and they stayed that number, but then we married up their name once they came to the hospitals. Great concept. Not sure where we're going to land, and that's part of what this community or this committee with AMR, Deer Park, and we're going to involve some other people. What's going to be our best initial tool that's going to make us successful so that we can identify these patients once they get to being put in the computer. In a perfect world, we'd be able to do it right on scene. Incident commander would pull right up, open up this thing, he'd have somebody step over there, and they'd start putting in data, and that would be great. That's not going to happen here in our region, mostly due to connectivity. So now we have to find another way for this to happen. There's several different things. One of them, and I hate to bring it up as our only resource because it's not. There's some other things out there, but you could wristband somebody with a set of number, you know, with a number of barcodes. Most of our new EMRs, you can barcode straight into their system, so you can marry them together that way. There's lots of opportunities there, and that's what we're exploring. But right now, the answer to that question is no. Nobody in town is using this patient tracking. We're still using whiteboards and paper towels when it comes to the emergency flood of patients. So. Anyways, and be respectful of people's time. I know it's 3:30, and is there any other questions I can answer right now? There's a lot more to come with this patient tracking, and we're excited about it. Oh, there we go. Oh, yeah, interested? Join the committee. I'm just throwing that out there. Mike Lopez and myself and Alina, we're heading this up. We're looking for all the help we can get. If you have any input on how this looks, let us know, because we're not the only people that are trying to think of how this to work. If you have an idea of how patient tracking looks to you as far as identification, please let us know. I need your input. We need your help. So if you want to get involved with that, there's our number. I'll happily handwrite it on anything you have. Okay.
Thanks, Mark. That's a lot of great work in moving us down the road where we need to be. So we truly appreciate the work, and like Mark said, he is looking for committee members to help with that great work. So the good news for all of you guys is it's been a long time since I was a Boy Scout, and I'm out of cheers. So we'll just wrap up the meeting with just a few notes and a few upcoming events. The sign-in sheet is on the back table there, so if you haven't signed in when you showed up, please sign in on your way out so we have a good count. We have your contact information, your emails if they're not there, so that we can send you alerts, updates, and notifications. One thing that did just come out is our Coalition Connections newsletter. It's a great way to keep updated on things that are going on with the Healthcare Coalition in the healthcare field. If you didn't receive this and you want to, please let us know. We can add you to the distribution list or make sure that you're receiving the information. It is really a great tool and a great resources to really keep in touch with what's going on around our region. And I truly appreciate the staff, Elena and Ryan, for making this happen. On April 28th, you probably also received an email. Spokane Regional Health District Healthcare Coalition is sponsoring a Crisis Standards of Care workshop here in Spokane. It's going to be featuring John Hick, who is a medical director and emergency room physician, really talking about exploring clinical, ethical, and legal frameworks of providing the best possible outcomes of the population as a whole under medical surge conditions. So it's a great conference coming up. I think it's going to be a great opportunity to learn about crisis standards, which continue to come up with how do we deal with medical surge events when we have limited healthcare system capabilities. So it's a great topic, something we were trying to keep up on everybody's minds. That is April 28th. I'll get to that in a minute. On June 1st and 2nd, you've probably also received notice about the Wish a Disaster Conference taking place in the Wenatchee Conference Center. It is also a great day-and-a-half, 2-day conference around hospital and healthcare emergency preparedness. If you want information about that conference, please let us know. The conference is free. You just have to cover your lodging and your food and travel. So it is a great opportunity. People have always given great results from that conference. So keep that in mind. And if you need any information about any of these things that we've talked about, on your agenda is also the srhd.org/HCC, or is that a /? HCC, it's in the bottom right-hand corner of your agenda. All of this information is on the website. They do a great job keeping our policies, our procedures, our plans, our upcoming events on the website. So it is also a great resource for you guys to utilize to keep updated. And with that, my last comment would be our next meeting is scheduled for March 24th. And I think the plan at this time is, as you remember, last November we had to cancel our mental health event, behavioral health reports and progress that we were planning to bring to the group. I think we're going to move that to the March agenda, so it'll be a great day to learn about what's going on around behavioral health preparedness in our region. So with that, if there aren't any other questions or comments, I'm sorry, but the weather's gotten worse instead of better since you've been here. But it's still not too bad to go home. Just be safe and be careful. Thank you very much.